Hello, everyone. It's a great honor and tremendous honor to be on this stage, and then lots of fun and pleasure to be with you today. I'm hoping you guys are enjoying a lot of great presentations, and also presentation plus with a lot of entertainments. Symposium at the Vegas, it's guaranteed to be fun. So today and tomorrow, I'm very looking forward to the whole symposium today. Today, again, my name is Dr. Kwan LEE, and I am from Seattle, Washington. And I've been practicing implant dentistry last 18 years. And last time when I was participating in the AMII Symposium 2019, I did present the CMC techniques using, crestal sinus augmentation using CMC techniques. Since then, 2019, 3 years pandemics, I got nothing else to do. So I've been playing around with a lot of CMC technique because, the sinus augmentation is one of my main passions, for that one. So today, my title is about the holy grails of the sinus membrane. Holy grails sounds very big, It's only from the movie, for that one. So, but the all-season dentistry, they have their own recipe to achieve the clinical outcomes to deliver the sinus augmentations. But there are also young generations, people who are coming from the newly trained or who haven't entered into the sinus augmentations surgical dentistry. And my presentation will be a little bit of a help them to guide to where to go and help them to guide to save their times. Within that mind, let's get started. Before we do anything, let's do our homework. So background. So when we're talking about sinus augmentations, these two things you're gonna be here every time. So Hill Tatum, he did the first lateral sinus augmentation in 1976. He was one of the pioneers, and then if he's not there, then probably we wouldn't be here. At the time, Tatum also, suggesting the idea of the approaching sinus membrane through the crystal LEE, but he was never be able to realize that idea. But 1994, Boyne and Sumners, they actually published the sinus augmentation through the crystal approach using the osteotomy techniques. So these are the two main pioneers when we are talking about the sinus augmentations. But when Tatum did the lateral sinus augmentation, at the time, 1970, think about it, we don't have any good instruments. All the instruments are very big and blunt. So when he actually removed the sinus membrane, the sinus window, there's nothing left. And then the hole has to be very big, to augment the bones and everything, for that one. So since then, we have a lot of modifications and developments for the sinus augmentation. Most of the modification is related to the osteotomy techniques. First, initially, when he did the Sumners, he did the osteotomy techniques. Number one reason why people are shy away is that they're malleting and hammering the patients. So those are the creating unpleasant experience. That's why a lot of doctors are shy away. So because of the reflections, a lot of people try to modify and try to tweak it away. So one is the bone-edited sinus crestal augmentations, hydraulic water pressure, and then using the piezo as well as water pressure, and balloons, intramembrane sinus techniques. So we have a lot of modifications. So, but do you know why we have so many these types of techniques? Because none of them are nearly perfect. When you try, I'm gonna try the bone-edited sinus techniques, but it's not living up to my expectations. So they tried a couple of times, but it wasn't my thing. So they are trying to shy away those kind of stuff. So that's why you see a lot of the different types of the method, techniques over there. 2007, Dr. Wang developed the CMC, crestal sinus approach. And then you see right now this is the diagram, but I'll show you actually this diagram exists in the real patient with a CT scan. The other thing also, I gotta be fair, when I'm doing the sinus augmentations, one of the significant advance or the development was the osteodensifications sinus augmentation developed by Hui Solar 2015. And I have a big question mark here. So in the future, are we going to have a more 100% foolproof of the sinus augmentation techniques? I don't know. Do you know this movie? If you know this movie, then you guys are old. This is one of the movies from a long time ago, Indiana Jones, and then he's looking for the Holy Grail. Holy Grail is Jesus, the one who drinks the holy water. And I don't know, it's a myth, or it could be really exist. We don't know, but I mean, this is everybody wants. However, it's very difficult to achieve it. If you have this one, then you can cure, you can get eternal life. And basically, all mankind's dreams are, condensed to these small objects here. So we are looking for holy grails of sinus membrane elevation. So do we have it or do we not have it? So let's find it out. When we're doing the sinus, any types of surgical dentistry, the headaches is the complications. You and I, we all share the same complication and the problem. When we're talking about the sinus augmentations, when we're doing the lateral sinus, then perforation is one of those complications. And also, when you're doing the crestal sinus the approach, the perforation is also headaches. And then the other thing is morbidity. You and I, we are the one that the front line with the patients. If the patient complains, we are the one that received all the the complaints. If the patient go through a lot of infection, swelling, and morbidity, we are the one that losing the sleep. We can't sleep, through several days. So these are the things that we don't want to have in our clinical life. So let's look at the consensus. From when we're doing the lateral sinus approach, about 6 to 42% membrane perforation rate. And if you've done the lateral sinus window, then probably you will agree there's a huge gap, 6 to 42. That's a huge gap. I think that's because of the surgeon's skill, and then sometimes the membrane also the patient's factor, but I guess many times surgeon skill, they account for 6% to 42%. And the other thing is meaningful, the study is a Fugazato in 2015, and then he looked at all the crestal sinus membrane and look at the case. And then he found out that almost 38% of the crestal membrane approach, 38% of the perforations. You and I, we all know that if you've done it, the crestal sinus membrane, then sometimes I know, gosh, I perked. You get the feeling. Sometimes you don't even know because there's no feedback. And then it also blind techniques. You have to rely on your haptics, sensitivity, or X-ray, but many times if you are using the hydraulics, water pressure, whether you perf or not, you don't know. So, and then most of the crestal approach, based on literature, they recommended 3 millimeters or less. So 3 millimeters is safe, tiny bit, very safe, predictable. Okay, I'll take that. But however, my patient, Mrs. Johns, comes in my office, and she needs about 6 or 7 millimeters sinus elevations. So what do we do in that case? Are we going to open up the lateral window every time? Or are we going to attempt to doing the sinus augmentation crestally and playing the roulette games? So that's a big question. So 2 things that I like when I'm looking at my, the techniques or the surgical dentistry. Y-axis, I'm looking at the predictability. If something works today, that thing has to work tomorrow. And if it works on my hands, that thing has to work in your hands. Predictability is a huge thing. If it happens only one time and doesn't happen tomorrow, it happens tomorrow and doesn't happen the other day, that's a very frustration. I don't know whether it's going to happen or not. So predictability is a huge thing. My other metrics is the morbidity. Just like I say, as a clinician, I want to avoid the patient's pain and their surgical experience. Because dentistry is different than from the medical. It's a lot of dentistry, especially implant dentistry, it's an elective service. So we want them to our patients to experience good, pleasant dentistry, the pleasant experience, so that when they coming back, hey docs, I need another implant. Versus, doc, I got an implant that's killing me. I don't want no implant. Just give me a denture or bridge. So those two things are that I'm looking for, for Leon. So now I want to give my personal. So basically, if you look at the right above, that's the Holy Grail. So if you find that one, then you satisfy predictability and morbidity as well. So these are my rating. Nowadays, internet generations, everyone give out their rating, their thumbs up, thumbs down. So I'm giving my thumbs up, thumbs down. My experiences may not be the same as yours, but at least I can give mine, and then you can give me feedback yours. First, litter sinus window, predictability-wise, highly predictable. It happens and it delivers the clinical outcomes. But when you look at the morbidity, it's still on this side, because I cannot ignore that there is more chance of that patient will go through more pain. So that's the thing that my rating. But if you look at the predictability-wise, it's really high. I know today is a minimally invasive symposium, but in order to do minimally invasive surgical dentistry, somehow you will have to look at the invasive dentistry as well together. So I strongly believe that lateral sinus it's got its own place. We may not do it every day, but at least you know how to do it. My next one is osteotome techniques. It's less morbidity, but predictability-wise, if I'm looking at the 5, 6, 8 millimeters membrane elevations, I don't know, good luck. So my predictability is very low on this one. If I'm talking about 3 millimeters, yes, you had it, go ahead and do it. Next one is bone-added, these osteotome techniques. This one is a little bit less morbidity because now you're adding the bone as a cushioning. Patient doesn't get the bang, it's a softer bang, but the predictability-wise, they're pretty much the same. Hydraulic pressures, morbidity-wise, yes, less morbidity, less painful because you are using the water. But predictability-wise, it's very 50-50, Russian roulette. Sometimes happens, sometimes doesn't happen. Same thing, piezo, using the hydraulic pressure with the piezo machine, same thing. Piezo is a very gentle instrument. It cuts only very, bone, very gentle vibrations. However, so it takes the less painful, but in terms of the more predictability-wise, I'm not sure. I've tried many times, but sometimes I do get it, sometimes I don't get it, sometimes I don't even know did I get it from there on. And my other techniques, the osteotome, the osteodensification by densaber, to me, it has some meaningful value. It's less morbidity, and it's close to the high predictable, from there on. The other technique is CMC techniques. So those are the ones that close to the Holy Grail based on crystal sinus augmentation. But let's look, this is the AMII, the symposium, let's look at the CMC techniques. So this is the actual case. Patient referred to my office. The referring dentist wants to have the extraction and then membrane elevations, and they wanted to have their patient back so that he can place his own implant. So initial CT scan, and again, this is the area number 13, 14, those area. As you see the initial sinus floor is very, shallow, thin, 1.9, barely 2. So basically, you follow the same protocols, for CMC techniques. You did the atraumatic extractions, I guess minimally traumatic extractions. Once you have the fresh extraction socket clean out, and then using the CMC drill, create the crystal bone bed, and then using the sinus lifter, you basically lifting the sinus membrane. So many times I know people showing the video clip, they are asking, how hard should I tap the patients, for that one. So this is the one. I know on the protocols, you should drill up to shy away from 2 millimeters away from the sinus floor. But depending on the bone quality and the bone density, sometimes they might be a little too heavy, so you have to tap it really heavily. So you can tap it really heavily, but my patients are very spoiled, so they don't like to be hammered down that much. So when I running into that, no matter how much I'm tapping it, it's not advancing it, then I use a drill to haptic sense, go up and down, create a little bit deeper crustal bone core. And this is a CT scan right after the, for that one. So this is not just from the diagram, actually the patients. Do you have a crustal bone core attached to the membrane? And then that's the little handles to elevate to the Schneiderian membrane. Again, this is the CT scan actually that's showing that it is itself, for that one. And this is again, it's sort of the blind technique, but and yet if you look at the scope with the loops, then you can actually see the crustal bone core is still attached to the membrane over there. And then you can using the CMC sinus bone membrane lifting, and then you can gently advance it, and then you can lift the membrane, from there on. Once the membranes are successfully elevated, then you can graft it with a particular bone, depending on your choice. So I use these types of the particular bones, and then as you can see, this is the empty void. That's the instrument, the sinus, the crustal lifter, and this is a nice, good umbrella shape. So that's the 9 millimeter plus the 2 millimeters. So you actually have about 10 to 11 millimeters sinus bone graft over there. So this patient's been sutured and then referred back to the restoring doctors, for that one. So this was my 2019 symposium in Seoul, Korea. Since then, I've been kind of playing around a little bit more. How can I make it better? And also, my question is, when I do the sinus grafting, sometimes you see the bump or dome. Sometimes they are very sloped, just like a tiny, umbrella. But what I notice in my case, like a Mother Nature, over the time, those dome-shaped umbrella bone kind of flattening out, just like air balloons. There's no air, coming down. So that's a couple of things that I noticed. So how can you make this membrane even flatter or more level? So the other thing that since 2019, I've been trying this method as well. It's called, I just named it, cartridge-assisted gel-type bone graft. So this is the bone graft encased in the cartridge, and this is the gun. All the dentists here, we are so familiar with the guns. Every time you did composite restorations, all the composite comes with the guns. So we have a good control of the gun. Plus, now there's tiny of the small cannula. So now I can push my bone to the direction that I want to. Before then, I only was able to graft it through the vertically, knowing that the bone's gonna be dispersed sideways. So let's look at this case one more time. Again, patients comes in my office looking for the implant treatments, upper right side. And this is a pre-op CT, again, very shallow, probably less than 2 or 1, for now. This is a pre-op. Same thing over here. This patient was a very elderly patient, so we didn't lay out any flap. So it's just a tiny bit of a tissue, the incisions, tiny bit of incision right here. and using the Sinus CMC bone, the trephine burr, and you drill up to since the initial sinus floor is very thin, so very carefully haptic sensation, the feedback, very gently drill into the sinus around the area. And this is a photo that I was able to elevate, this is about 9 or, I forgot the numbers, about 9 or 10, for that, so I was able to elevate around it, from there on. And this is the bone core from the patient's sinus. So this is the part right here, that's the floor. This is a part that I was able to retrieve from the sinus, the burr. Sometimes, the sinus lifter, it's got an empty hole inside, and then when you retrieve it out, this type of a crustal bone core, it's stuck inside, and you can actually see that this kind of bone core. Once I know this sinus being nicely elevated, then I'm introducing this, the cartridge, bone cartridge. Then I can manipulate my directions. I can point it towards the mesial directions. I can point it towards the buccal directions. I can point it towards the distal directions. So not only I'm gonna have a nice, not the umbrella, but my membrane is gonna be elevated like just as if I did a letter approach. So again, everyone wants, show me the CT, show me your proof. So this is the pre-op. This is the after the cartridge. I was aiming towards the mesially, I was aiming towards the distally, and then above the superior borders here. So I'm measuring the CT about 13 millimeters around this area. So I got very tiny hole, and then I was able to introduce the bone, gel type bone, towards mesially and distally. So now your membranes are here, level. And the other thing also, from the X-ray, the membranes is intact because I don't have any bony particles, like a little smoke coming out from the bottom. So I don't have any bony particles around the area. So that one's, it's good so far. And this is a sagittal view from the CT scan, pre-op and after. I was gonna go for a little bit more ambitious, go for a little bit more, but 7 millimeter plus the 2 millimeters, the residual depth was enough, 9 millimeters, so it's only about this much. So this is the cross-section of the bread. If you think of this types of a bony material from mesial to distal, you have a nice bone grafting on sinus. Sinus membrane, okay. So this is the final outcome, sagittal view, and this is from the panoramic view from the sinus, the graft. So since then, 2019, I've tried these types of gel types of cartridge assist the gel type bone grafting. Seems to be works nice, and you got more control. Who wouldn't want more control? And besides, these bones are very like a gel type or creamy. So it's much friendlier on the sinus membrane. Sometimes membranes are very, almost very thin. So sometimes I notice that if you are introducing the very hard bony particles, like 250 micrometer size of the hard bony particle, that small, it creates small micro tears on the membrane. On the X-ray, it looks nice, but when I see it later, then I see something different. So I think that this types of gel types of bone grafting is also very friendly for your Schneiderian membrane. So now let's go back to our first questions. So did we find the holy grail of the sinus membrane? I mean the crustal approach? I don't know. I'm still hungry. I'm still looking for here. Maybe we just drink the water. Maybe we just take the medicine. And then the membrane just goes up. I don't know. Everyone has a different idea. But until then, I think that this is a good choice. Until what we are looking for, this is a good choice for the sinus crustal augmentations. When you guys are doing the maxillary posterior case, half of the time you're gonna running into Sinus, whether you like it or not. So if you have your own recipe, then good for you guys. Or if you are still looking for your recipe, then this might be a good time to try. Thank you.